of wear and tear in the cartilage, we now know better that it really involves most of the tissues in the joint. And this is a pretty wide spectrum of tissues to study, so I'm going to be largely focusing on the tissues in the joint. And as I just mentioned, cartilage has received by far the most attention because for a long time we thought that arthritis was a disease just of cartilage. Now cartilage, its primary job is to facilitate the transmission of loads, and it does this both by absorbing some of the load, but also providing a smooth, low friction surface so that the joint can twist. Now, physiologically, cartilage is a pretty boring tissue. It has no blood supply, it has no nerve endings. It's about 1% by weight cellular. So chondrocytes make up about 1% of the total tissue. Most of the cartilage is actually made of water. This is just hydration. And then there's this extracellular matrix composed of collagen and proteoglycans with glycosaminoglycan side chains. And they act to provide the structure as well as to provide the water retention that allows cartilage to do its job. Now, as I was mentioning before, at a late stage in the disease process, you get breakdown of this extracellular matrix leading to loss of hydration and loss of tissue. Once that happens, that's largely irreversible. And so what we want to detect is early changes in this collagen and proteoglycan network that we can detect at an early and reversible stage to allow us to intervene. Now, while I say that cartilage is a very boring tissue physiologically, it's a very interesting tissue from an MR standpoint because many of the properties that break down when cartilage breaks down have unique relaxation mechanisms that we can study to actually identify what's going wrong. So there's dipole-dipole coupling, and again, I'll just assume that you learned everything from Mickey's lecture yesterday, but essentially this is a relaxation mechanism where water that is tightly bound, each water dipole creates its own magnetic field, and that will affect the magnetic field that neighboring dipoles see. So if something is very tightly bound, it has a large magnetic field on its neighbor, leading to faster signal loss, signal dephasing, as opposed to something that's free water, which is able to move around a lot more and exhibits less of a magnetic field on its neighbors. So this gives us information about the collagen network where the water is bound to. As it breaks down, the water becomes more mobile. And proteoglycans, and in particular glycosaminoglycan side chains, they have this property where the hydroxyl group, this OH group on the proteoglycan, it is actually in natural exchange with that of bulk water. So again, this leads to loss of signal and faster relaxation, particularly T2 relaxation, as well as T1 rho, which I'll get into. And we can leverage that to study proteoglycan degradation. Then there's also diffusion. So the main way that nutrients are transported into the cartilage is through diffusion of the synovial fluid. And so if you have really intact extracellular matrix, you have more restricted diffusion, whereas once that breaks down, you get more free water and more isotropic diffusion. And so there is no shortage of quantitative MRI methods that have been made to study this early breakdown in the extracellular matrix, and I'll just touch on a couple of those. So probably the most widely used is T2. All of those relaxation mechanisms that I just talked about affect T2 relaxation, but in the cartilage, the thing that primarily drives T2 relaxation is when the collagen breaks down, you get less restricted water movement, and so that leads to an increase in T2. And so we sort of think of increased T2 as a sign of collagen loss. And this has probably been the most widely utilized quantitative method, largely because it's the easiest. You can do this by acquiring T2-weighted signal with multiple echo times and then fitting an exponential or something more complicated like fitting it to an extended phase graph model or block equations. But this is a sequence that's on scanners without needing to do any sort of modifications. Just the multi-echo spin echo is what's needed. It does have its challenges, though. I was giving you that relaxation mechanism, dipole-dipole relaxation. That mechanism is actually affected by the orientation of the dipoles relative to the magnetic field. Something known as the magic angle effect, where that mechanism essentially goes away at 55 degrees relative to the magnetic field. And so it's really tough to compare T2 values between different parts of cartilage. And as a result, and just the natural variation, we rarely use this as an absolute. We'll look at change over time as a predictive measure of future changes. And as I mentioned before, this is largely driven by collagen, and it's thought that the earliest change that we see in cartilage is actually loss of proteoglycan. So the thought is that maybe this isn't sensitive to the earliest changes. To try to prove on that, people have developed a method called T1 row relaxation imaging. And the idea here is to get more sensitivity to proteoglycan. So I'm going to assume that you all picked up on all of Mickey's rotations. I wanted to get at least a few turns in. So in a T1 row relaxation experiment, in the laboratory frame, I'm going to try to repeat Mickey. So you have your circularly polarized excitation pulse and activation. So it goes around and then gets you down to the XY frame. And so you apply this 90-degree pulse, and then you apply a secondary pulse that's parallel to your activation in the Chandler's plane. And so then again, you're still spinning around, and now this is relaxing and phasing in the presence of a magnetic field. So when we look at this from a rotating frame of reference, we flip down and then we apply this spin lock pulse parallel to that. And so what it does is it probes some of these slow rotational relaxation mechanisms that we think of occur with collagen and even chemical exchange effects. So if we think of T2 as being spin lock amplitude of 0, essentially, it's sensitive to all of these mechanisms. But when we apply a larger spin lock amplitude, we start to lose relaxation due to some of these low frequency events like B0 and B0 homogeneity. And then as you see here, this dipole-dipole coupling, that has a much lower frequency correlation constant compared to chemical exchange, which is due to proteoglycan. And the thought is, ideally, to just remove this mechanism and make it sensitive to proteoglycan. In reality, you can't really decouple these, and so I like to think of this as we become more sensitive to proteoglycan loss, but we can't really decouple the two. Nevertheless, it's slightly more sensitive here, but it comes at a cost. This T1 row pulse requires a lot of increases the SAR quite a bit, and so in addition to the higher RF power, which is particularly challenging at higher magnetic fields, it does require a very specialized pulse that isn't normally available from the members. The last method I'll talk about is the GEMRIC. This one is the most sensitive to proteoglycan, and it takes advantage of the fact that these GAG chains are negatively charged. And so if you inject a negatively charged contrast agent, wait for it to diffuse into the cartilage, it'll distribute in reverse proportionality to the GAG content. And then you can do T1 mapping and see that this T1 shortening agent is most present in areas of low GAG. So it's very specific to GAG, but it has its own challenges, as you would imagine. It requires quite a long scan. You have to inject it To speed up the diffusion into the cartilage, you'd have the person walk around or walk up and down stairs. Then you'd have a delay to allow even more diffusion in, and then you'd image. So it requires a long scan. You have to do an injection. It's expensive, and then obviously it's contraindicated for people with renal dysfunction. So while it is the most specific to GAG, and you can do it at high resolution, the fact that all of these negatives has really also limited its impact. And so again, there's lots of methods. They have various biochemical specificity, but the main thing that I want to point out is we spent a lot of time looking at what are we imaging? Is it collagen? Is it proteoglycan? Is it some combination of the two? But the reason I highlight these three is because there have been studies that show that if you see changes in these parameters, that they're highly predictive of disease progression. And that's the most important thing. There's actually a lot more methods. I didn't want to go into all of these. From an MR standpoint, these are all fascinating, like sodium and GAGSUS. But from a translational perspective, they all have very limited potential. Now, I've largely focused on cartilage. And part of that reason, again, as I mentioned, was that cartilage was the tissue of interest for a long time. But part of it is that some of the other fibrocartilaginous tissues in the joints are hard to image. They have really short T2 values. And so when you get a normal conventional MRI, you actually, at an echo time of 30 milliseconds, which might be something that's PD weighted, you don't get any signal there. Again, that's not really problematic because most of the time we like to detect the fluid that shouldn't be there that's indicative of damage. But from a quantitative standpoint, that's obviously a challenge. And so there's been a lot of work more recently in using ultra-short echo times to try to probe some of these tissues. And again, once you go down to an echo time of 2 milliseconds, and I've removed the PET signal here because it can confound our dynamic range, you start to get signal from meniscus, and I'll show you in a bit, you can even visualize bone. And so again, ultra-short echo time has allowed us to apply the same type of methods, for instance, T2 star reoxidation mapping, as well as T1 row in the meniscus, and same idea here. There's been studies that have shown that as you get damage to this microstructure, the T2 star goes up, and that differentiates between different injuries, as well as evidence to show that this predicts future degradation. Okay, moving on to some more functionally interesting tissues. So next I'll talk about the synovium. And the synovium is this really thin layer of cells that encapsulates the entire joint and holds the synovial fluid, which is used to provide nutrients to many of the cartilaginous and fibrocartilaginous tissues. Now, when there is damage to the joint, oftentimes what ends up happening is this tissue gets irritated and inflamed. And we know that inflammation is both something that causes pain in patients, but is also a target for treatment. So there's a lot of work being done on trying to understand what is the pathway of this inflammation and designing particular drugs that aim to target that. Now again, from an imaging standpoint, this is quite interesting. So on conventional MRI, the synovium, and particularly the inflamed synovium, is really difficult to image because it's almost always present next to synovial fluid or effusion fluid. So you can see that here, that we have this big, large fluid effusion, and we can hypothesize that there's probably synovitis there, but we can't visualize it because you just can't differentiate it with contrast-wise. So we call this effusion synovitis. Now, we can, if we want to better differentiate that, we can do a contrast enhancement. And so contrast, when we inject gadolinium, this is preferentially taken up by the inflamed synovium, and so we get this large drop in T1, and we can visualize synovial hypertrophy really well. Further, we've heard a lot about DC MRI from the previous speakers. We can do something similar. So if we measure the uptake over time, we can assess things such as K-trans, which is the efflux of the tracer from the blood pool into the extravascular pool. And this gives us a measure, essentially an indirect measure about the intensity of inflammation. Now again, this is actually one of the success stories for quantitative MRI, because this is now starting to be used in drug trials. And it's not being used in drug trials to evaluate whether the drug is working. It's actually being used to identify the patients that are likely to benefit from an anti-inflammatory drug. If you don't have synovitis, you're probably unlikely to benefit from an anti-inflammatory drug. So again, from a drug trial standpoint, that's actually a really big point, because people think that there have already been drugs that work in OA that just haven't shown efficacy because we haven't found the right patients to put it into a drug trial. But outside of that, these techniques really aren't used, and synovitis really hasn't been particularly well studied in osteoarthritis because no one wants to give a gadolinium injection. And so that's led to the development of some non-contrast techniques to try to assess this. So one technique that we've tried is using a double echo in steady state sequence. This provides 2 echoes with 2 distinct contrasts. One is the first echo is a T2 over T1 contrast, and the second echo is more of a T2 and diffusion weighted contrast. And one thing to note here is that the free water and the fusion, it doesn't really have much of a signal change between the 2 echoes, but the synovium does. And so if you do a subtraction, a weighted subtraction to all the fluid, you start to be able to visualize synovial hypertrophy. And we've recently shown in a trial where we studied people getting ACL surgery, ACL reconstruction surgery, where after surgery you see a big influx in synovitis, and then after 6 months after that, both due to time after surgery as well as an anti-inflammatory treatment, we were able to show that the synovitis decreases considerably. Now ideally, we'd actually like to be able to assess the inflammatory activity, because that has clearly been shown to be a better marker of synovitis, particularly for giving drugs. And so in the same way, we'd like to be able to come up with non-invasive markers to correlate with inflammatory activity. And again, this is where quantitative MRI potentially has a role. It appears that in synovitis that there is diffusion properties which correlate with the amount of activity. So here we correlated with K-trans done with BCE. One challenge we have here is that we actually have to use the contrast enhanced imaging to identify what was synovium and what wasn't synovium, which obviously defeats the purpose of doing a non-contrast exam. So we're trying to use inspiration from what's been done in other tissues, primarily the brain and the breast, to try to use IVAM to differentiate the free water diffusion in the fusion fluid from the constrained diffusion in the synovium, using IVAM to remove the signal of the fusion fluid and then solve the TI parameters. Where am I at? Okay, so bone to me is the most interesting tissue in the joint because unlike cartilage, bone is really well vascularized and it has the ability to remodel itself relatively quickly in response to changing load or micro damage or whatever it may be. It's also one of the tissues that's a primary driver of joint pain, as if your cartilage isn't functioning, you don't get pain from your cartilage, you get pain from the high load that your subchondral bone feels. Again, we have lots of ways to image bone. MRI usually doesn't directly image bone, but we can see damage to the bone as fluid that shouldn't be there. But again, these are structural changes, so we want to get at earlier points. I say that we don't normally use MRI to image bone directly, but using UTE and ZTE techniques, we can now get down to echo times where we get signal from bone. We can even do long T2 subtraction to visualize the bone in isolation. And this has been particularly useful for trying to do surgical planning with MRI. So normally, oftentimes, we'll do the MRI to identify the pathology, and then the surgeon will want a CT to do the surgical planning on. And so CTE methods are particularly nice in that bone has very little signal while everything else is iso-intense, and so you can do just an inversion and you get really good CT-like contrast, which can also be used for bone rendering, which the orthopedic surgeons also really like for surgical planning. But as we heard from the many wonderful diffusion talks we had today, this is another area where we can use some of these MR properties to get at tissue properties that occur at a much smaller scale than what we're able to image. And in particular, we can start to probe the porosity of the bone. So in the cortex, these pores tend to be very small, something on the order of microns. Now, MR obviously doesn't have that resolution, and we definitely don't have the signal to noise to try even something relatively close to that resolution. In fact, even for CT, you need to get down to micro CT to be able to measure cortical porosity. However, as I was mentioning before, as the tissue changes, the relaxation properties changes. So water that is bound to bone has a really short T2, something on the order of tens of microseconds. However, water that is in pores, particularly bigger pores, has much longer T2s. And so if we can differentiate the amount of signal that has a short T2 and the amount of signal that has a long T2, we can actually indirectly measure cortical porosity. And this is quite important because for diseases such as osteoporosis, if you have a lot of loss of bone, a decrease in bone mineral density, that's pretty indicative of osteoporosis. However, there's this in-between window where you don't lose bone mineral density, but the bone that's laid down isn't very structurally sound. And so those people are not labeled as osteoporotic, but they're still at risk for fragility fractures. And being able to detect this porosity can improve on our ability to predict who's at risk for these very high mortality fragility fractures. And so people have done this to isolate these two compartments and have shown that this correlates somewhat with bone mineral density, but even more so, it's been shown to be a better predictor of mechanical strength. Now, even that method to study microstructure, those changes are still relatively, still takes